I do only is PSLD surgeries, uniportal, because this technique I learned it from Dr. Lin, my mentor. I do only is uniportal endoscopy, no transforaminal, no biportal. This technique is PSLD. Founder is this technique, Dr. Lim. Everybody is known his name. What is it? Technique. This is you are saying is lumbar spine anatomy, because some schools in Europe. And I saw many conferences and some schools landing point on the facet. First, they try to find facet, then have to remove some part of facet till find SAP, and just doing flammectomy and removing discarnation. I think this technique also good, but not all time, because in my cases, more than 60%, 70% my cases with discordation in stenosis. If we do this simple discectomy, this is not full surgeries. My technique is basically technique is landing point should be on the spinal laminar junction. Everybody is hearing me?
Yes, we can hear you.
But we cannot see you, Dr. Akhror. Can you change the position?
Maybe make, yeah.
It's visible?
If you come closer, maybe we will be able to see. Now we see only background.
How is now?
No, we can't see you. Only the bridge behind.
Oh, let me.
Maybe if you switch off the background, we will be able to see.
How is now? Now is visible?
No, not visible, unfortunately.
Oh, I'm sorry. Not visible?
Not visible. Professor Hassan, maybe we can continue and after the presentation, when Dr. Akhror will stop sharing the screen, he might be visible more, I don't know.
Yeah, maybe.
Okay.
Okay, should I continue?
Okay.
Yes, it's okay.
Yeah, okay. This landing point should be spinal laminar junction. Why? Because even if little discarnation here should be lateral root stenosis. If I landing point on the facet, we cannot reach. We can reach contralateral side, but a little difficult. If we do landing point is lateral spinal laminar junction, and first we have to remove base of spinous process, and we have enough space to reach contralateral side. And first we have to open middle part of spine canal, and from middle to lateral, step by step till the end, till we reach dural margin, and this was when we see dural margin, this is stopping step, and because some schools first do is bone work, too much bone work, then remove butterfly ligament and flume. I don't do like this because why I do this technique, we have to preserve both facet joint because this is for lumbar spine. No, I mean, is for our spine, facet joint is more important part. That's why during surgery we have to preserve this joint. And I think this specialty technique is very good during surgery. And, in my surgery, no facet damage. That's why this technique is becoming more popular. This is also on the X-ray. First, when you start basically intralaminar surgery, you should see AP view X-ray. It can help for you. This is landing point, this is lamina, this is interlaminar space, this is spinal laminar junction. If we landing point here, we have to remove some part of facet. That's why this part is spinal laminar junction. It's a safe part. We don't destroy anatomical structure. We have to save all bone structure. We should remove, for example, one level bilateral decompression. Maybe this much bone. We should remove this. See, here it. I don't touch facet. Till here is lateral margin of dura. Our is lateral border. When we remove piece of spinal process under the process, we can reach contralateral side also. In contralateral side is absolutely no damaging facet joint. Only I remove which part is hypertrophy facet joint is pushing medial dura mater. This part I usually remove, but the main part of facet joint I always try to preserve. This is I'm trying to explain to you one simple case. This patient was operated before 2 times. First, open surgery. First was L5S1 discectomy. Second is 4-5 right side discectomy. And still, patient after surgery, some improvement was, but not completely because upper level of the 3-4, there is canal stenosis, bilateral isovascular stenosis. That's why two surgery couldn't help for patient because patient his before surgery patient had claudication, no pain, no little numbness. Main problem is claudication. Then I try bilateral. My plan is left approach because right and left is the same is lamina. If sometimes it's spinosis approach it's tilted on the right, sometimes tilted on the left. If like this is on the right side tilted, left side approach is better. If sometimes it's right side tilted, it's spinosis process, right side approach is better because which part we have is more space on the lamina. This part we have to do approach. This 4-5 also before open surgery did only one side decompression, but here is still with stenosis. This is view also this is with stenosis. My plan is do 3-4 bilateral decompression and 4-5 only is ipsilateral decompression. This is basic tips of PhD. How to hold scopes. This five finger. This is stopper. Because all this part is for the thing. This finger is support all for this part. And the other fingers is for fixing cannula and holding scope. This how I'm using is the drill. This my finger is the stopper. We have to put always like this because sometimes it drops inside. It's totally is the major dural circuit. That's why is always we have to put stopper. And this is drawn by Dr. Laukos how to hold his cup. This video, without hurrying, I just stop which part is required, and I describe this anatomical. I told 3-4 left side approach. First, we see when we put the cannula on the spinal laminar junction, is first we see some muscle on the lamina, and this muscle we have to remove. When we remove this part, this anatomical part is we can see this is lamina. This is cranial side, left, this is right caudal side, is 12 o'clock is medial, 6 o'clock is lateral. It's facet joint. Here is, we can see it interlaminar space. This is lamina. First, we have to remove lamina in a laminar junction. Usually I use, when initially I use Kirsten 2 punch. If sometimes lamina is very thick, I use drill to make thin. In thin part, I can remove with Kirsten so fast. Yes, this is Kirsten 3. Kirsten 3, 9 is cranial, 3 is caudal, 12 is medial, 6 is lateral. It's all we are seeing is the ligamentum flavum because the bone is not strong. That's why I'm not using drill. Is with Kirsten 3, Kirsten 4 here is very important step when we reach attachment part of flavum, and this is a cranial stopping point. And from cranial to caudal, I start remove flavum. When I hold flavum and I rotate scope, I have to see under the person because I make sure my person is not holding is dura. This is very important. Sometimes is stenosis between the ligamentum flavum and dura mater. There is adhesion. It could be the dural tear, dural damage. That's why when I hold this ligamentum flavum, I rotate my scope and I have to see my kerosene tip. Make sure this is not holding, it's not biting dura mater. Yes, this is fat tissue. Usually have to clean because it's also sometimes irritating. It's not visible. Dura. See, it's very easy to remove ligamentum flavum with Kersen punch. And it's very safe also. Yeah, this is ligament is the fat tissue I'm removing because first I open this middle part is because of stenosis is bulging dura. Now I'm removing is ipsilateral side, not is contralateral. Because I rotate scope, I'm removing is ipsilateral side. Now is the contralateral side. This is 3 o'clock is contralateral side. We see is Kirsten is easy going to contralateral part in reaching dural margin, and because of some difficulty, I couldn't remove I couldn't reach. That's why I removed a little part of more base of spinous process. Now is my Kirsten is reaching his contralateral side also. Yes, I'm using Kirsten 2 punch for contralateral. Yeah, I make sure is I check it the time X-ray. I have to remove more is cranial part. This is Kirsten 4. See, it's very safe. We can control is Kirsten the total under the vision. Yes, this ipsilateral already I did decompression. Already I'm seeing lateral margin of dura. This is ipsilateral, 5, 6 o'clock. Okay, now is contralateral also is little part, cranial part I am removing, and I make sure is the lateral rectus should be free. See, is I'm not touching facet, just I'm removing which is hypertrophy part and which is hypertrophy part of ligament of flavum. Now is totally is I'm checking with dissector. This is lateral width is totally free. No compression is here. Yeah, contralateral. So some bleeding should be. Yes, it's I think it's finished.
Servicio?
No, Spanish, English.
No.
Would you like? Okay.
This is I'm now checking is with the sector is dura is very is mobility, no pressure, no compression is here is totally free. That's why I check is cranial caudal side is because on the MRI sometimes it's more caudal stenosis, sometimes it's more cranial. That's why I always check cranial caudal side. Usually is between from pedicle to pedicle. We have to open independence in which pathology. This is let me show. Post-op MRI is immediately I do second the post-op MRI because before discharging, I mean patients always I do with MRI. This is before surgery, have stenosis here. This is after surgery, it's totally open. This is here. This drainage. I put L5 is done also. Lateral width is not. I did the compression. This axial view is this 3-4 before surgery. See, is it after surgery? See, here is right side and left side. I didn't touch facet joint. Is I preserved because of this is more important. You see, this is I under the spinous process. I did this contralateral decompression. This is drainage. I put on the Dura. This see post-op MRI is no hematoma because of drainage. In see before surgery we cannot see the roots because of stenosis. See after surgery all roots we can see totally recovered. This fluid flow. And here also see is no muscle damage. This is more important part also. This L5 is found on left side. I did only lateral wrist stenosis because here is no patient before surgery and no symptoms, only claudication. I tried this part also open because sometimes this after surgery will irritate. That's why I did one time to surgery. Thank you so much. This is my I have this specialist lab for training is monoportal spine surgery. If someone is interested in to learn to try and find out a good place to learn specialty, you can come my hospital. I will teach because every day I have 4-5 cases, at least 1-2 cases, sometimes 6-7 cases also I do. That's why observership also for training is good because more 50-60% my cases not a single level is multi-level cases. I do is sometimes 5-6 levels also one time. This practice, these skills you will have also when you visit my hospital. Thank you.
Good. Thank you so much, Dr. Akhror, for your great presentation. 1 second. Yes.
There is no
I have
visible
one
still?
question. If anybody has also question. Yes, we unfortunately still cannot see you.
Oh, I'm sorry, it was something happening.
Maybe something wrong with your camera. So if anybody has questions, please put them to the chat box. So my question is, which patient will you not definitely take for the uniportal endoscopic treatment? The trauma, age-related, or
Yeah. Is if I don't do intradural tumor, and which is trauma is usually I don't do in trauma cases because in emergency hospital did, and all degenerative even is spondylolysis also. I do endoscopic. I do is percutaneous screws, and I do. I put this cage under vision scope. I think is 99% pathology vertebra I do is endoscopic.
Okay, thank you. And what is the? I understand. So you are already experienced surgeon, but after the one is going through that learning curve, what is the time of surgery? The least amount of time which you can take to do single level.
Single level usually 25-30 minutes enough. Even less. Sometimes I do more fast one level single decompression 13 minutes. And for last week, I did 6 levels, one patient for 3 hours. Each level about 30 minutes.
Mhm. Thank you. Did you have any experience when you had to switch to open surgery because endoscopic for some reason was not intra-op was suitable for patient or
Yeah,
more? Mhm.
no, in my practice, I didn't have because even duratomy also is big duratomy also. No problem. I put this endoscopic suture.
Mhm. Okay, thank you. So it gives to all the residents and young neurosurgeons hope that if you learn properly, so you can start and finish with endoscopic equipment. But
Yeah,
it's
it's
all about learning curve. Mhm.
yeah, learning curve also important because I started during pandemic. It's 2020 in July I started.
Mhm.
Before that, I learned on this animal model.
Mhm.
And this equipment also very important because some equipments, some company scopes I tried to use, but I couldn't. No, this because I use, for example, this RivoSpine or in Europe using is for bilateral decompression more
Mhm.
drill. I use more Kirsten. That's why my
Oh.
Kirsten have to strong. I use this Korean company Kirsten, very nice. No, uh, because before from Europe, from US, also some I have some students. They came and many surgeons, usually the young surgeons, they are thinking is uniportal endoscopy is limited. And
Mhm.
uniportal endoscopy cannot do anything. But it's wrong theory. After seeing that the surgeons also see also can do is uniportal can do everything, no problem. Because in my hospital, they had everything 4 or 5 cases. I did
Mhm.
cervical, dorsal, is the more is lumbar, and I
Mhm.
think is because learning curve is very difficult. I agree, this uniportal. But when you learn is after that is you will be king.
Okay, great. And you don't have any age limits, right? So you can take any patient.
Yeah, if
Mhm.
for surgery, if not contraindication, I do. Maximum my patient's age was 96.
96. Mhm. That's great. Okay, Professor Hassan, do you have any comments or questions?
I have no. Do you hear me? Okay.
Yeah, we can hear
Yeah,
you
yeah,
and
yeah.
see you.
Okay. And actually, I have no question, but I want to say that I had the pleasure of meeting Dr. Akhror in Tashkent this year.
Yeah.
I thank him once again for his hospitality. And I want to say that we will be honored to host him in İzmir. We will be
Yeah,
waiting.
I think I will be in İzmir is in February next year for Dr. Murat is organizing next conference. I think
Okay, but
we'll
this
meet
conference
there.
is
Then I think.
nothing with us. Nothing. So, okay. Anyway,
Yeah, if you organize,
we-
Dr. Hassan, no problem. If you organize
okay,
any workshop or conference,
okay,
I will go. No problem.
okay. Thank you. Thank you so much.
We also have Dr. Narantiran who joined us today. Maybe he has some comments.
Who?
There is Dr. Narantiran. He is the doctor from United Kingdom. I know him, but he joined, but not visible. Okay. So if anyone has questions, Dr. Celine, maybe. Actually, the topic is really interesting, but like it was said before, it requires a learning curve and maybe some workshops, cadaver, and under the simulators. So
Thank you very much.
hello,
Professor.
sir.
Yeah, I just managed to unmute it. That was a fantastic presentation. I really enjoyed and learned. So thank you very much for the talk and to the organizers. Thank you.
Thank you. Okay.
Thank you for everything, Dr. Yakubov, Professor Suju, and Dr. Nargis. And as far as I can see, there is no any comments. I can close the session. Good evening, everybody.
Thank you so
Bye-bye.
much.
Bye.
See you next time. Bye bye.
Bye.
Teşekkürler.